I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to what I'm going to call a very special episode of Women's Health Unplugged. I am really excited to have this conversation. I'm joined today by obstetrician gynecologist Dr. Mathew Leonardi, and we are talking all things endometriosis today. Mathew, thank you so much for joining me on the podcast today.
Thank you so much, Dr. Robertson. It's a pleasure to be here. I'm an avid follower of your Instagram account, and I support a lot of your messaging and the work that you do. And so I'm very honored to be here. Thank you.
I am so excited to have this conversation. And really, the way I found you was actually through patients. So I work as a naturopathic doctor locally, similar to you, working in Hamilton, and I work in Burlington, Ontario. And I started sort of hearing of you through patients, which I was so pleased that I was getting this feedback from patients that we had, well, they were calling you a new gynecologist in Hamilton at the time, that they felt like they were really being heard when they were in their appointments. And that turned into me looking you up and being interested in a new gynecologist who's interested in endometriosis. And so I'm really excited for us to have this conversation because of just how difficult it is for women to get sort of accurate and timely diagnosis with endometriosis. So I would love if you could kind of open and walk us through, how did you get to this place, like in your career, from, going through your path for medicine to get to gynecology? And then how did you pick endo as a specialty? Because I feel like it takes a special person to treat endometriosis patients. And so I'd love to hear how you got there.
Absolutely. You mentioned that I have an interest in endometriosis. I would go one or maybe multiple steps further and say I have an intense curiosity. Some may even call it a bit of an obsession with the entity of endometriosis, the disease of endometriosis, which I find absolutely fascinating from a medicine sense, a science sense, but also a psychosocial sense, how much it affects people. I have to say, I didn't intentionally fall into the endometriosis sphere. Often things happen by accident in life. And when you find an opportunity that works well and it clicks, you run with it. And so for me, the journey started pretty typically as an OBGYN resident in Toronto. I really found my interest lied more with gynecology than obstetrics, but the kicker became my love for ultrasound. I had some incredible experiences with sonographers in Toronto who taught me the beauty of ultrasound and the utility of ultrasound, but it didn't align with my interest in gynecology so well, because in Canada, people who do imaging for gynecology are radiologists, not gynecologists. So I had to seek opportunities outside of Canada to find that sphere of medicine that I wanted to be in, gynecology and imaging and ultrasound. So I went to the United Kingdom and I went to Australia, and this is where the passion for endometriosis really started to blossom, because as you know, it's very difficult to diagnose. In gynecology, we use ultrasound as our first line imaging test for almost everything. And for endometriosis, it's almost always useless, or that's at least what my impression was when I was in Canada as a resident. So when I finished my residency and I went to Sydney, Australia for my fellowship, I worked with Professor George Condis, and with him as my supervisor and mentor, learning the intricacies of gynecologic ultrasound and advanced gynecologic surgery, endometriosis became the centerpiece. It lit up as this most fascinating condition that bridged both of the worlds of diagnosis using imaging, advanced surgical skill, and then once you get deeper and deeper into it, it's like you cannot get out. It's so fascinating. So I started my PhD while I was in Sydney at the University of Sydney, and I've been doing research in endometriosis now for about 3 years, but extremely immersed, and there's certainly no escape for me at this point. I'm in, and I'm in for the long haul.
It's such a cool story. And like so I want to go back and highlight a couple of things there, but what you said about like the ultrasound, it's interesting because even like when I have spent time looking at endometriosis, like we just considered ultrasound to not be part of the diagnostic conversation at all, right? And even we would never even hint really at endometriosis. If women had had an ultrasound, we would just be like, nope, we cannot tell. And can you walk us through like, why is that? Like, our gold standard for endometriosis has always been laparoscopic surgery, really. It was always like the kind of 2-for-1. We'll go in and look and see if it's there. And if it's there, we'll maybe remove it. But can you like inform our listeners a little bit about, like, let's take a step back and talk about what endometriosis actually is, and then why has ultrasound been so like not considered a diagnostic gold standard?
For sure. So endometriosis, as most listeners will know, is a benign or non-malignant gynecologic entity that affects people who are born with uterus and ovaries. They may not identify as women anymore or ever, but certainly it is an affliction that occurs in people who are born with those organs. It is a condition that affects outside of the uterus. It affects the ovaries, and it affects the tissue that exists outside of the uterus, generally in the pelvis, less commonly, but still commonly within the abdomen, and then more rarely outside of the abdomen in places like the chest, the lungs, the diaphragm. And so the standard of care ultrasound in Canada and in North America, and around most of the world, to be honest, means looking at the uterus and looking at the ovaries. So if you're only looking at 2 general structures on an imaging test, and the disease entity primarily affects outside of those 2 structures, you're not looking for it. Therefore, you're never going to find it. The standard of care ultrasound in Canada for endometriosis is wrong. It's actually missing the mark. Most ultrasound in North America is performed by sonographers or technicians, and those images or videos that are acquired are saved, they're read and interpreted by a radiologist, and a radiologist then prepares a report and sends that report back to the referring doctor. So the report will say, uterus looks like this, ovaries look like this, and that's it, nothing else. As many of you know, endometriomas or ovarian endometriosis are a common presenting way of endometriosis. So that is one way that ultrasound has historically been able to identify this disease. But endometriomas look like other ovarian cysts sometimes. And so when radiologists are interpreting it, rather than performing it and interpreting it, they may not be able to tell the difference between an endometrioma and a hemorrhagic cyst, for example. So there's always a degree of uncertainty on the imaging because, 1, we're not looking outside of the ovaries, and 2, ovarian endometriomas might be something else. Now, where are we going, and where are things at in places that I consider centers of excellence, including my center, I'm very proud to say? We're looking outside of the uterus and the ovaries. We're looking at the bladder, the ureters in the front of the uterus. Behind the uterus, we're looking at the bowel, the rectovaginal septum, the posterior vagina, the uterosacral ligaments, which are the most common site for endometriosis to deposit. We're looking at the cul-de-sac, also known as the pouch of Douglas or rectouterine pouch, which is this potential space that is between the rectum and the uterus. Often the bowel falls into that space. We look at that space because that's the space where endometriosis mostly exists. It's where the uterosacral ligaments are, the rectum is. Endometriosis, for all intents and purposes, has a dependent nature to it, which means it falls due to gravity. The lowest part of a female pelvis is that cul-de-sac. So most of the disease accumulates there. So again, if you're not looking, you're not going to find it. At our center and centers that have adopted advanced imaging principles, we're looking at those spaces. And we're able to see endometriosis in those spaces very reliably. So I currently dislike when people talk about laparoscopy as the only way to diagnose endometriosis. Certainly, it is a reliable way to diagnose endometriosis, but it is not the only way at all. And if you ask any of my patients who I scan who have visible disease on ultrasound, I tell them very clearly, you do not need laparoscopy to diagnose this. I'm telling you, it is endometriosis definitively. So laparoscopy is not the only way. And the other piece to that is laparoscopy is not perfect. You can miss disease on laparoscopy. Pathologists who are evaluating biopsied tissue can miss disease at that assessment as well. Every person along the diagnostic journey is a person. Nobody is perfect. And each imaging test, each surgery that's done, each pathologic assessment is operator dependent. So no, there is no perfect diagnostic test. And in medicine, that's true about everything.
It's so interesting because women often get approached for support, or even they're curious about a diagnosis with endometriosis. Usually the thing that drives them into the office is their pelvic pain, right? And what one of my goals has been in my career, and I'll talk a little bit about my journey with endometriosis too, is that I want women to lower their tolerance for menstrual discomfort, because we generally can see that we sort of dismiss this symptom in people in general, and we've normalized some level of pain, meaning that many adolescents and many young people who suffer from menstrual discomfort actually fit the criteria of being assessed for endometriosis, but because we've kind of normalized that experience of menstrual pain, they never tell anybody about it, or they never go, right? And it's not till I'm sitting across from them doing a fertility assessment and I'm like, tell me about your cycle. And they're like, well, aside from the like 40 Advil I need to take, everything's fine. And it's really the first time anyone's evaluated their cycle dysfunction. But really what drives women into the office, or people into the office, is pain. And then to have a scan that shows that everything's fine is not exactly a validating experience for those people.
You're totally right. For me, the ultrasound utility, my own performance of ultrasound and on the spot interpretation of ultrasound with my patient sitting there has opened my eyes to the importance of validation, and validation beyond simply saying, your experience is real, but validation in a tangible way. So I don't like diagnosing endometriosis because nobody wants really to have this condition. But of course, when people have symptoms, they want an explanation. So one of my favorite things to do is to turn the screen and say to the patient, who I'm literally scanning right then and there, this is the endometriosis that's in your pelvis. This is the bowel nodule that you have. This is the uterosacral nodule that you have. Here's your ovarian endometrioma, and here's where it's completely stuck to the pelvic sidewall. I do this routinely because the lack of validation that people have experienced for years, whether it's from their mother, maybe their sisters, their female relatives, or their male relatives as well, but usually it's going to be the female relatives who are saying, you got to just deal with your period. Then moving on to their family doctor, their gynecologist, everybody who's always told them it's normal, just deal with it. You turn the screen and you say, this is not normal. You have this disease here. And there are often, I would say the vast majority of times, tears in those moments when somebody learns of the reason behind the pain that they've been experiencing for a very long time. And more than pain, to be honest, bowel symptoms, bladder symptoms, fertility issues, fatigue, the list goes on, right? So that validation is so important. And I've been privileged in my role as a sonologist and ultrasound specialist to learn that from my patients.
Mm-hmm. And so I'd like to talk a little bit about just that patient advocacy piece, because how do patients, and I have my own opinions about this too, but how can patients kind of get the ball rolling? And even if they're sitting at home listening about this, podcast about menstrual pain, Like, how can they start that journey towards getting better assessed and getting that validation from either a diagnosis or just from someone that they're working with?
The first thing I tell a lot of my patients is they get to define what a problem is for them. So, I mean, I think most people who have a period have some degree of cramp associated with it, some degree of bowel changes, maybe. So, for somebody who is experiencing that, who's not bothered by it, who's living a full life, not limited in a personal or professional context, that's fine. But if somebody defines their issue as a problem for them because it's impacting them, that's when it needs to be taken seriously. That's when the person needs to speak up for themselves to their physicians. Sometimes if you're, a young girl, potentially to your parents, to get access to a healthcare provider. And when you do see that person and they try to normalize your symptoms, it's important to say to the person, actually, this is a problem for me. And whether you think it's normal to have a period pain or not, for me, it's affecting my life in this area and this area and this area. And I want you to help me with it, rather than saying, okay, it's normal. Truthfully, in medicine, family doctors, they see so many patients who come in with lots and lots of complaints across every aspect of the body, right? And maybe not most of the time, but a lot of the time, reassurance is what is needed, right? A lot of people don't actually have a diagnosis. They don't have a problem that needs intense assessment or medications. Reassurance is something that family doctors do and should do. But if the family doctor tries to reassure you and you believe that it's a problem, I would not stop there. I would tell them that it's a problem for me and I would like you to help me.
That's really great advice. On top of that, I would say, like, sometimes going in with some, I'll call it like tracking or data or things can help solidify that conversation around pain. So I always ask my patients with endometriosis to track their painkiller use, right? Because it helps us see there's progression over time. We've got a little bit of research on how we can maybe drop that number down, right? The number of Advil you're using in a month. But it also helps quantify that experience to your practitioner. So, if you have one headache a month, right, versus if you have 25 headaches a month, that actually changes our diagnosis, right? It's like, it's not just this one random headache. There is a serious situation going on that we're going to investigate further. And it's kind of the same conversation with menstrual cramps. The one Advil, but you can get back out on the soccer field, right? We're maybe not considering that pathology versus, needing to take multiple painkillers over multiple days beyond those menstruating days, right? Because women with endometriosis often have pelvic pain at other times in their cycle. That tracking which days in your cycle you have pain, how many painkillers it takes for you to manage it, and the loss of function is really important. So, if there is no returning to the soccer field, then we definitely have like, it's worthy of investigating further. So I get my patients to kind of like evaluate at what, like, how much dysfunction do we have because of this? I mean, certainly we want people to be optimal, right? We don't even want them to play soccer in pain, period. But it's a communication technique in medicine that we want to know, like, how much does it interfere with your life, and that can help sort of start that conversation with your practitioner.
You're totally right. And we do that in our center to quantify people's experience, not necessarily for validation or diagnosis, but actually to understand progression. How can we help you improve, right? And like you said, you might be able to reduce the number of Advil somebody needs to take. So that's a metric. That's really quite objective to denote a decrease in the pain experience that somebody's having. I would say for maybe the first visit with a physician or healthcare provider, that can sometimes be interpreted, and I'm not saying this for my center, but overbearing, a bit too intense, aggressive. And the reality is, it's a bit sad to say, medicine still has very much a paternalistic mentality. There's still a lot of attitudes, there's still a lot of authority there. So sometimes going in to see somebody with the diagnosis already and the treatment plan already and the really long list of things can sometimes do the reverse of what you want. It can create a countertransference where the physician almost dismisses you because you're seen as hysterical. And I completely disagree with this mentality at all, totally, because, I think patients should be empowered and they should understand their health entirely. So, if you approach your family doctor and they say something like, oh, it's normal. Well, first of all, they shouldn't, but the next thing to do would be to, go home and start to track things at that point and bring it back to them and say, look, over the past 3 months, I have tracked my daily pain scores. I've tracked my gastrointestinal symptoms. I've tracked my days that I've had to take off work or off sport or off school. And this is objectively me telling you that there's something wrong besides me coming in and saying I have painful periods, right? So there is a need to be still a bit cautious in the approach because of that sort of historical culture of medicine, which I think we need to move on from, but we also have to acknowledge that it currently still exists.
Mm-hmm. I know it's interesting. Like 15 years ago, when I started practicing, I've always been like deeply interested in endometriosis. And I was telling you a little bit about my story off camera that I actually kind of found endo by accident. I really could not find a project to do for my third year advanced immunology project when I was in undergrad, and had to find, it was supposed to be some sort of new and novel concept in immunology. And I'm not a creative human being. I didn't know how to find a topic. And so I literally think I was like, 2004 new immunology things. And we came up with, or I found a few papers looking at the immunological impacts of endometriosis, which at the time, this was a relatively novel concept that the immune system was involved and there were T cell papers and whatnot. And I did my project on endometriosis, which then turned into me being incredibly passionate about this particular subject for all the reasons you've said, right? It's like, the disease itself is fascinating. The treatment leads, I'm not going to call it an overhaul. It just needs some evolution in the way that we treat patients. We can't just slap the birth control on this situation because we just don't see the improvement that those women and people deserve. And it has such widespread impact on their quality of life, their fertility, their experience of their hormones. That's what sort of like kept me interested in endometriosis all this time. Like, what's our current, like, I'd love to hear from you because now you're really enmeshed in the research and I am not, about like, what do we understand about endometriosis right now? Like, as far as like cause, and what are some of these treatment targets that we should be thinking about for women like moving forward?
I think we might have taken the same immunology class. You said you went to McMaster as well?
Yeah.
I think we did. I was there from 2004 to 2008. So we might have crossed paths.
We might have crossed paths briefly. Now you're just saying, I'm just like a hair older than you.
Age is irrelevant. To answer your question, it's we need literally an entire semester to talk about the origins of endo and the treatments of endo. Certainly, the origins of endo still remain very mysterious. There are relatively newer theories that discuss concepts like the embryologic theory, meaning when you were a fetus, cells developed and implanted incorrectly during the actual embryologic development and remained there dormant until puberty, at which point the pituitary ovarian axis gets initiated and estrogen, progesterone, LH, FSH, these hormones start to arise and the disease is then triggered. Estrogen is the primary driver of endometriosis. So this is a relatively newer concept that exists, and it can explain patients who have weird sites of disease. It can also explain patients who have very deep-seated disease. I recently had a patient and operated, and they had what we call parametrial endometriosis. This is endometriosis in the retroperitoneum. So the retroperitoneum is not exposed at all to the environment within the abdomen and pelvis. It's not exposed to the fluids or the blood or the ovulation. It's deeper. It's within the actual sort of deeper aspects of the pelvis. And you have to realize that this disease has been there for an exquisitely long amount of time and had to have been seeded at some point many years before it actually became problematic. So the embryologic theory is very interesting. Certainly there are theories around stem cells and the development of cellular material within the pelvis. So the endometrium as one of the most regenerative types of cells in the body. There was recently a wonderful article, I believe it was in the New York Times, that was written by Dr. Linda Griffiths, who's in the States. She's an engineer, and she was talking about how the uterus holds so many secrets to health because of its regenerative abilities. It changes every single month over and over again. So Hugh Taylor, who's a gynecologist in the States, has been working very strongly in this area of the stem cell theory. So these are some of the more novel concepts. Of course, there are still the old theories, the Sampson's theory, the metaplasia theory, and to a degree, they still hold some validity. There is the recurrent nature of disease, of endometriosis, after it has been removed. And so is that because the disease is being reseeded by events like retrograde menstruation? Or are there remaining cells within a pelvis after excision has taken place that are not removed because they're naked to our eyes, and then they have the ability to regenerate? So it's still a fascinating territory, to be honest, but we don't know all the answers. There is likely an immune component as well, although it seems relatively clear that endometriosis is not an autoimmune condition. And doesn't have this association with other autoimmune conditions that might be a bit believed in the social media sphere. I see quite a bit of posts about this. Marina Kavaskov and Stacy Mismer's group, they're a wonderful big epidemiology group in the United States and in France, and they've done some wonderful work demonstrating the associations between endo and other autoimmune conditions, or lack thereof. So your second question is, what about treatments, right?
Yeah. Yeah. I'm curious around, I have lots of questions about treatment because I think often when women land in my office, it's because they're looking to try and conceive and they feel like that goal is kind of diametrically opposed to the solutions that have been offered to them for their endometriosis, right? So that's usually where they walk through my door, or they've gone through multiple steps in kind of the treatment ladder and feel like they're running out of options because they've tried like two or three of the solutions. Or I get women in my office who maybe need support in like sort of advocating for treatment options that are not on the table for them at this moment. And love to talk about that a little bit. But I think there's a couple of classes of options for women as far as support and medications. I mean, we can just go through that sort of generally, but I think one of the gifts that you bring to the table is your willingness to let women be autonomous in their treatment choices and how they proceed with treatment. And so I want to touch on that too.
For sure. I sort of look at endometriosis treatment options like a buffet. I imagine a room full of treatment options and a patient standing in the center of that room and looking around at the treatment options and saying, I'm interested in this, or I'm interested in this, or I'd like a smattering of this and a bit of that and a little bit of this. So I sort of think that, first of all, endometriosis needs to be managed in a multimodal fashion 100% of the time. I do not believe that any single treatment entity is enough, whether that's medical therapy, surgical therapy, or complementary and alternative therapies. I really think that people need to embrace a multimodal treatment approach. Now, for some people, they might start with a multimodal approach, find one thing that works well, and really just want to stick with that one thing. And again, that's perfectly fine because at a buffet, you get to decide what you eat. There's no set menu. There's no courses. You decide.
You don't
So
have to have the crab legs.
I love crab. But no, you don't. You don't have to have things that are there that are options. And so this is one area that I really do differ in my approach to managing endometriosis than a lot of doctors who are a bit more algorithmic. The challenging thing about endometriosis, there's a million challenging things about endometriosis. One of the challenging things is that treatments have been hard to find. They're limited. And because of the challenges, doctors who see more than just endometriosis patients, unlike me, who's primarily endo, they need to follow rules. They need to have guidelines that teach them how they should treat patients. And guidelines are very algorithmic. They don't lend well to autonomy, to patient choice, because if you have a guideline, then you follow that guideline. You're told, I need to use this first. If that doesn't work, then I use this. If that doesn't work, then I use this. But the general nature of medicine in Canada is very guideline based, and it is around the world, because not every single person who's an OBGYN is going to be doing their PhD in endometriosis. And truthfully, if you come to me with a problem like discharge, I'm not an expert. I might look at those guidelines and say, here we go, this is how we should start, but that's not my area. No OBGYN is real, well, unless you become a super subspecialist, no OBGYN is going to be able to have advanced level knowledge and skill in each domain of gynecology, right? So I think of treatments as a buffet, and I have the three broad categories, which is medical therapies, surgical therapies, and complementary and alternative therapies. And each of those is an umbrella term for multiple different agents. And most of the time, there's some combination that's happening. One really strong underestimation in the realm of endometriosis is that it generally evolves into chronic pain. It might start as period-specific pain, but it becomes a bigger problem than just period-specific pain. It becomes non-cyclical in nature, daily pelvic pain. It becomes related intensely to the gastrointestinal system, where people experience bloating, nausea, pain with bowel movements, constipation, diarrhea. Many people are incorrectly labeled with IBS due to this association. So if it becomes a new entity on top of the base of endometriosis, we cannot fall back on single therapies like hormones or surgery, because those are not going to work. They might work for a portion of the pain, but they're not going to work for the broad scope of things. So you can ask my patients, almost all of them are being recommended to see a number of allied health professionals. And truthfully, the main core person, in addition to me, is my pelvic floor physiotherapist, because the pelvic floor muscles become so involved in this disease due to their protective nature. When people experience pain, those muscles have a tendency to become tense. They clench. When people experience pain during sex, those muscles clench and they become protective. And they require a lot of work in the process of reversing the chronic pain. So I know we can talk a lot more about the more intricate concepts around treatment, like medical therapies, hormone therapies, surgical therapies. So I'm happy to go into that if you like, but I'll let you direct me.
Well, it's more, I think, what I'm curious about. Like, I love the way that you kind of describe that as a buffet, right? And I think for most patients with most conditions in Ontario, that's not how they feel they get to navigate the healthcare system necessarily. It feels like there's hoops that they have to jump through in order to qualify for the next thing, right? And sometimes even we do that with lab testing. It's like, well, we'll start with this. And if it's grossly abnormal, then you qualify to have some other testing done. And so just going back to that whole validation piece, like our time to diagnosis for endometriosis for women is long. And by the time they have been formally and accurately diagnosed and offered treatment, they do have that risk of transitioning into more of a chronic neuropathic pain syndrome than it just being menstrual cramps, right? And I think that the more knowledge that women have about this and the more that they can advocate for themselves through that process, it's a simpler way to try and shorten the time to diagnosis than it is for us to overhaul the entire culture of medicine. It's just to teach the patient. But I love the way that you describe it there being a buffet, because there's so many benefits of each of those treatment solutions that you outlined, but there's also challenges with each of them as well. And so I do feel like my patients with endo always feel like they're kind of like, there's so much risk benefit, calculation going on with them, that I've been offered this therapy, but it has the likelihood of causing weight gain, or I'm really, this maybe would be my top tier option, but the risk is that I'm going to, not be able to conceive during this time. And so to know that they actually get a choice in which of the not perfect solutions they get to choose from, I think there's something special about that, right? I think that that puts a lot of power back in their hands, and probably has better outcomes. We generally know the more autonomous patients feel, the better they do, regardless of what we're talking about.
Yeah, there was a nice study published in the JMIG, which is the Journal of Minimally Invasive Gynecology, that looked at the response to surgery, how people did post-operative after excision of endo, and the study quoted, and it's not exactly, my numbers are not exactly on, but roughly 60% of people had an improvement after surgery, so 40% didn't, but 90% were very happy that they proceeded with surgery. So they felt like they had control. They got to consent to doing something. And even though it didn't help them, they were happy they did it. Now, surgery for me as a diagnostic test carries a lot of controversy, because I do believe that there is a therapeutic value to diagnosis. One of my new slogans is diagnosis is therapy. And I do believe that if your surgery is both diagnostic and meant to be therapeutic, it is kind of difficult to separate the therapeutic value that you get from learning about what you have to the actual excision or the treatment. They're completely intertwined. And so maybe to a degree, this is why there is some evidence to say that no matter what, after a surgery for endometriosis, people feel relief for maybe 3 to 6 months, and then there's this resumption of symptoms. Is it that there was this really profound gratitude to know, and that knowledge translated to control, translated to decrease in fear and anxiety, and that has significant therapeutic value? Or does the disease come back, 6 months later? So I think one of the things we need to move towards is keeping surgery for therapy and finding non-invasive diagnostic tools, one, so we can significantly reduce this diagnostic delay, and two, so that way we can better start to understand the true therapeutic value of surgery, which I do believe that there is. And I think that's very important for me to say, because there is a very strong mentality that gynecologists in Canada don't think surgery is very good for endometriosis. And I disagree. I think there is a massive role for surgery for endometriosis, but it needs to be contextualized in the patient's journey, in their evolution of endometriosis to chronic pelvic pain. It needs to be one of the items in this buffet. And one reality is that people need to understand that surgery can make things worse. It can lead to post-surgical pain, and it can lead to no improvement if none of the other avenues of the multimodal approach are utilized. So it's another fascinating talk. We could do a whole podcast on surgery for endometriosis, I'm sure. But I'll leave it at that for that point.
I think you raised some really great points there, right? That just that validation is going to make a big difference for those patients. And if we had better diagnostic techniques, or if we invested in better diagnostic techniques, is maybe the better answer, because we have them, they just are not widely available. That it would actually, anytime we have to go in to a patient to diagnose them, obviously we're underestimating the number of people that suffer with that condition, right? We're bottlenecking the whole diagnostic process with the surgery. And so that's why there's been this conversation around us lowering our tolerance for cramps, because if we make the surgery the diagnosis, we're only checking so many people at a time. We're underestimating how prevalent it is in the population. What do you think about the CA-125 test? I'm curious what your thoughts are, because that's for me, like, that's one of the only things in my scope that's possible for me to help support people in their journey towards a diagnosis. I can't send patients for an ultrasound. I obviously do not do surgery in my office, but that's an available resource. I'm curious what your thoughts are there, where we stand with the blood markers for endo.
Currently, biomarkers for endometriosis are should only be used for research purposes. They should not be used for clinical purposes yet. The reason is when you think about a diagnostic test, they have an ability to rule in something or rule out something. If those numbers are, if those percentages for their ability to do that are not high enough, then they don't carry very much value, and sometimes they actually have harm. CA-125, many people know, is a tumor marker as well as a potential marker for endometriosis. In the world, CA-125 is usually used to help diagnose ovarian cancer and understand progression of ovarian cancer with treatment. It is elevated in people with endometriosis. It's also elevated in people with things like fibroids, adenomyosis, other ovarian cysts. So if you have an elevated CA-125, it doesn't tell you you have endo. It could be any one of those other entities. If you have a low CA-125, it does not rule out endometriosis either. So our recommendation amongst the people who are leading the up-to-date SOGC, the Society of Obstetricians and Gynecologists of Canada guideline, is that right now it should only be used in research settings. And I do think that there is a role for biomarkers and potentially CA-125 in routine clinical use in the future. Myself and my colleague at McMaster, Dr. Jocelyn Wessels, are actively exploring biomarkers in addition to ultrasound. So actually combining the two to provide that non-invasive diagnosis, particularly for those that have what we call superficial endometriosis. So we haven't quite delved into the sort of three subtypes. We briefly talked about it when we talked about the utility of imaging earlier. But to summarize, there's ovarian endometriosis, there's deep endometriosis, which generally is around 5 millimeters in size and very reliably identified on ultrasound when done by somebody who's trained. But the third category is superficial endo, which is very, very small endo, millimeters in size. Can be very difficult to see on ultrasound, although one of my areas of my PhD is in diagnosing superficial endometriosis on ultrasound. But I acknowledge that I will never be able to diagnose all people with superficial endometriosis on ultrasound. So if we're looking for the non-invasive savior, it's going to be a biomarker. And it'll likely be a biomarker that we combine with ultrasound. Because we won't need to use biomarkers in people who have deep endo, who have ovarian endo. Those people can receive a radiologic imaging diagnosis. So it's those that have a normal ultrasound, a normal advanced ultrasound, after looking for those advanced disease subtypes, that biomarkers will play the role. I just want to say one thing more about CA-125, which is that we see a lot of people who have elevated CA-125 that is being done for the workup of endo, and many of them end up going down a journey of evaluating for ovarian cancer, and that can be a very anxiety-provoking journey. It could even result in surgery to remove people's ovaries. In the process of trying to diagnose that ovarian cancer, and part of the limitations in that process comes back to the lack of high quality gynecologic imaging to tell somebody that they don't have ovarian cancer using imaging. So I just want to caution the use of CA-125 because we don't want to send people down very wrong pathways that make them worse or create really a severe undue anxiety.
That's totally fair, right? When we think about like why we're doing lab work in the first place, right? It's maybe to tell us something we don't already know. It needs to do that with high reliability. It needs to be better than or more accessible than like the current treatment options. When I think about like where my limitations are in practice in Ontario, it's a thing that's on a requisition that I can use as an advocacy strategy for patients to get maybe the pass through the gateway of family medicine to a gynecologist when we maybe haven't been able to raise the attention before. But it comes with that like massive disclaimer, right? That like this doesn't it's not a rule in or a rule out strategy. Actually, it's a conversation starter, and it shows up in lots of other quite sinister conditions, and we're going to open a big can of worms if it comes back positive. So I agree with you. I think that it raises like that whole challenge with like the diagnostic like path that women have to move through, that if there's limited access to good technology, then we in like either family practice or otherwise end up falling back on markers that are maybe not specific or not helpful. So I love that insight.
Yeah, and
Um,
it's hard. I feel really quite a lot of sadness for our patients because they're desperate to know what's going on. Right? They are willing to do surgery to get a diagnosis, and
mhm.
that that is telling because that's how bad the disease is. Right? If you're willing to have a general anesthetic and have somebody put like a scope into your abdomen, which you could die from, like it's extremely rare, of course, but that could be a negative
There's
adverse event,
risk. Yeah.
right? Like that's how desperate people are to have a diagnosis. So I think most people are going to say, yeah, do the CA125 because I mean the worst thing that's going to happen is I'm going to have to go see a gynae oncologist if my CA125 is elevated and somebody happens to think I have ovarian cancer. You know, they want to know. So we need to really convince the healthcare providers that are still not convinced that diagnosis is important.
Mhm.
There's this, it's there's a huge disconnect between our patients and healthcare providers who believe that all we need to do is tell our patients we think they have endo. That's okay. We think you have endo. Let's start you on the birth control pill. Let's start you on Lupron. Let's start you on Oralisa. And that's okay. And patients are saying, no, I don't want to start these hormonal medications that come along with a big side effect profile for a disease that I don't even know that I for sure have.
Mhm.
So there's a huge gap here.
Right. It's almost like we want to use those medications as the rule in strategy, right? It's like, well, we'll give you this, and if it gets better, then we're probably right.
I have said
When
that in many notes, and one should not use medications as a diagnostic test. It's not appropriate.
it's not appropriate. No, because give people Lupron and lots of things go away, right?
Totally, yeah. You suppress the whole uterus, the whole ovaries. One of the things that is often mistaken for endo is the presence of recurrent hemorrhagic cysts. These are relatively physiologic events. The ovary, which ovulates, makes a follicle, ruptures that follicle can bleed. And that bleeding event can be very painful, extremely painful. And it's not just a 1 second event during the rupture, that pain lasts for days to weeks. If that happens with the next menstrual cycle and the one after that, people become in a constant state of pain due to hemorrhagic cysts. So if you treat somebody with hemorrhagic cysts with Lupron or the birth control pill, you're going to fix them because you're suppressing their ovulation. But if you're doing that under the guise that you're going to try and diagnose endometriosis, well, you're going to be treating the wrong condition here, and you're going to label that patient with a chronic condition that is got a lot of baggage associated with it, and that has major implications.
Before we wrap up, I would love to talk about the social media piece because I don't even know, can you even handle going and looking at some Instagram profiles about endometriosis? Like there is quite a lot of conversation. And I think that always stems from people feeling either unheard or unsupported, right? When we see people looking for wacky and creative ways of dealing with their disease, it's because it's a population that doesn't feel like they're getting a lot of answers. And then suddenly a green smoothie detox for 14 days looks like awfully attractive because no one's given them any hope up until that moment. But I'm curious to know what your thoughts are around like some of the like myths that are perpetuated online about endometriosis and how women can kind of navigate that information with some caution.
Ooh, this is a big bag of worms.
Talk about baggage.
So look, the reality is that we live in a world where social media is necessary. It is our way of learning, it's our way of communicating, it's our way of having creative outlets. It is not going away, at least not for the foreseeable future. And it has provided a window for people to connect with each other. And that's really important in the realm of endometriosis. With the various players in the social media sphere, I think one thing that we have to always come back to is everybody wants to help. Everybody wants to do their best. Nobody is intentionally trying to create harm or sell bogus things. I mean, some people certainly do monetize from their career as a social media influencer. That's very true. But I think at the base of it, people's intentions are actually quite genuine and pure. And maybe they can get misguided along the way, especially if you start to develop followers. And I think, most of us who are on social media, that line gets blurred sometimes, What am I here for? Am I here for me? Am I here for the greater good? It's challenging. There have been studies that have identified the reality around misinformation. There's a study that a couple of my close colleagues and friends have done, James Duffy and Martin Hirsch, looking at Googling endometriosis. And most of the material online is not correct. I would say even from some of the accounts that are healthcare providers, physicians that I follow, there is a lot of misinformation. A lot of it is around the diagnosis. Many people are perpetuating laparoscopy is the only way to diagnose endometriosis. And I think one thing that patients need to be aware of, and this has come up on social media a lot, whereby people are calling out those who have disclosures with pharma, but nobody is calling out those who are making their money by being a surgeon. This is an elephant in the room. I'm a surgeon. I make money from doing surgery. In the United States, where there is a privatized system, people make a lot of money to do surgery. In fact, I have had several patients who are on the wait list here, and they want to go to American surgeons who charge $12,000, $20,000, because those people are advertising surgery as the only solution. And people who have endometriosis, who have chronic pelvic pain, are desperate. We've touched upon this, right? So they see those posts, they see that advertising, and they think, my goodness, I have to go do that. But there's no declaration, there's no disclosure that they make their money by being a surgeon. We all have disclosures. You have a disclosure. The pelvic floor physiotherapists who are on Instagram, they have a disclosure. The dietitians, we all have disclosures, and that's being, I think, missed by a lot of people. We need to interpret what's being sold to us very carefully. There is a lot of truth, though, on social media. You can find truth, but I encourage people to seek out references, seek out where the information is coming from. This applies more than to just endo, in particular now with the whole COVID vaccine saga and a lot of misinformation about that as well. Like, seek out references. Who is talking to you about this? Where are they getting their information? How can you become educated to really make the decisions that are right for you based on truth? So it's challenging. We all face this challenge, right? Because we live in a social media sphere, in a bubble. So I don't have all the solutions.
I know those are pretty good answers, though. I will say, I feel like it's interesting. Like I do value the social media experience for patients. Like even when I started working with women with PMDD, those women found help because they found Facebook groups that validated their experience, right? 10 years ago when we maybe were not quite as adept at finding some of these concerns in people, they found their voice or their diagnosis through talking with other people who suffered the same as them. And so I do think there's incredible value in that. I do think it's challenging because I always say no one hops on TripAdvisor to talk about their mediocre chicken, right? They all hop on to talk about the food poisoning, and it can taint the way that patients feel about the buffet, right? Like all of a sudden we've got these treatment options. They're like, oh, I read about that. And this one girl I know in Utah, she had a horrific experience. So it's tough because you don't get to see, and this goes for the COVID vaccine too, you don't get to see the statistical power of Linda's experience in Utah when it's presented as equal as, or even more as loudly than someone's very positive experience with a treatment, right? And so I think having that mentality, like it's TripAdvisor for treatment options often, and we don't get to hear like sort of the entirety of women and people's experience of treatment options because people don't do that on social media. You don't get on and say, my endo pain kind of sort of got better when I did this, even though medically we may find that really helpful. um, so I think that's an important piece to remember too, is that those, like the voices we hear and that ones that are the loudest are not always the ones that are the most correct or the most representative statistically of what we actually expect to have happen with a particular treatment. But I'm still amazed that like 10 or 15 years later, social media wise, that when people end up in my office to talk about endometriosis, the things they've read about online from an integrative perspective are not the things we have the most evidence for. I keep waiting for this day that someone will come in and say, I've heard this is helpful. And I go, you're right. That is helpful. That we're still kind of having conversations that are maybe not, especially in my world, that are maybe not the most evidence-based supports or solutions for patients with endometriosis. We're still having conversations about things that are not evidence-based online. So yeah, that's kind of what I think about it.
You're totally right. And I think medicine as a whole is partly to blame because there's ample research, right? But it's behind paywalls and it's not accessible to real people. All of the research that's done, which is as best as possible, our evidence-based, what we can believe to the highest degree is not accessible to real people. What is accessible to real people is anecdotal evidence. And there was a recent Twitter debate, let's call it, where one of the biggest advocates was talking about their large population of patients on their group, and that experience with that group of people is extremely valid and extremely useful, but it is not peer-reviewed scientific research. It is not analyzed in a way that is digestible. It is not peer-reviewed to the point where the flaws of that scientific method can actually be assessed. And it's not published in a way that's accessible to people. But there's a lot of messaging that the truth is based on this very large population of people. But that's not the case. On the flip side, medical research is also not the case because medical research is highly restrictive. When you're trying to do a study and you need to define your study population, you have to be very, very specific, very refined in who's going to be part of that study. So it may not be generalizable to the entire population of people. So, there's flaws on both sides of medical research and anecdotal reports using social media. And so I think for people, it's important to have access to both, but right now they do not have access to the medical side of things. Some journals are starting to be more open access for people to read whatever is published. One of the journals that I'm an associate editor for, Reproduction and Fertility, has a lay summary for every article that's published, and it is also open access. So this journal is very forward-thinking in that they know that the real people who are the receivers of healthcare want to have access to this knowledge, right? They should have access to it because it's going to be how they make their decisions about their treatments in their future. So I think that's the direction that we need to move, where medical literature and the real life experiences of people that are posted all over social media are accessible to those who are making treatment decisions for themselves. I think we also need to be aware that the placebo and nocebo effects, nocebo being essentially the opposite of the placebo, are realities, and they're not things that people make up. They're actually biochemically driven events. And one of my colleagues, Dr. Burke, who's at Sunnybrook, he and I are really starting to delve into this process around endometriosis, because lots of people have read the posts on social media to say, Linda from Utah had a really bad experience with her birth control pill and she gained 30 pounds. And so if I take it, I'm going to gain 30 pounds. Actually, your body is not Linda's body. You might do extremely well on this medication. And it's always quite a surprise for a patient when they come into a visit with this thought that they were going to have a negative side effect or a bad experience, and the medication works really well for them. And they're like, oh, well, I was not expecting that to happen, but it has happened, and I'm grateful that it's happened, right? So we have to be aware of these preconceived notions that we come in to a visit with and how they actually impact on the outcomes that we experience.
I'm so grateful to chat with you, Mathew. I feel like you are such a visionary for this conversation in this disease. I'm sure we're going to have multiple conversations over our careers about this. I would love, as we kind of wrap up, what's your sort of big take home message that you want people to know about endometriosis and your work? What's your Sona soapbox moment where you can tell everyone what your mission is?
Wow, that's a hard one, Jordan. Wow. I feel like this whole podcast episode has been a bit of a soapbox moment for me to have an opportunity to share my thoughts. And again, I'm very grateful for that. And I absolutely agree. We're going to have lots of really interesting discussions as this field of medicine evolves. Really, at the end of the day, one of my largest goals is to improve the diagnosis, because I think we need to start validating people in a way that is more real for them than just telling them, we acknowledge you have symptoms and we think you have this disease. So I'm really pushing very hard to enhance the utilization of imaging in Canada and in the world. Ultrasound is very accessible, it is very cheap, and it is very safe. Having a transvaginal or transrectal ultrasound, if you cannot have a transvaginal ultrasound, can provide you with so much information that really negates the need to have a diagnostic laparoscopy. If we're going to do laparoscopy, it should be reserved for treatment. So I want to really encourage the adoption of more advanced imaging principles for endometriosis. And those principles are going to be extrapolated far beyond endometriosis into the realms of infertility, fibroids, bleeding problems, other pelvic pain entities, right? So many gynecologic problems are underdiagnosed because our imaging is limited, and we need to amplify that. So for those people who are here listening, reach out to your doctors and tell them that you want advanced imaging for your pelvic pain, for your bleeding. You want to know the diagnosis. Have a look at my website, have a look at my social media. You'll see things that you can ask your doctor to look for. Deep endometriosis, obliteration of the pouch of Douglas, which is looked at using the sliding sign. If they start to write these things down on their requisitions to their radiologist, and the radiologist doesn't have any clue about what these things are yet, they're going to look them up because they're going to say, what is this referring doctor asking me to do? That's going to change the dialogue. It's going to push the envelope forward, push people to do what's right for patients and what's right for this population. So really, advocating for that, speak up for yourself, be very autonomous in your decision making. Don't let doctors tell you what to do. Tell them what is important to you. They should listen. I could go on, but that's good. That's enough. Thank you.
It's perfect, actually. It's perfect. Diagnosis is therapy. Mathew, thank you so much for your time. And we'll put all of the links to all of the places that people can get better connected with you in the show notes. Go follow Mathew on social media. That's how we got connected after I had such positive feedback from my patients. Thank you so much for your time.
My pleasure. It was great to be here. Talk again soon.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.